speaker is Dr. Daniel Leifer. He is a third-year dermatology resident and board-certified pediatrician, the best kind. He attended Stanford University, where he studied biology and international security. He went to medical school at the University of California, Davis, where he was a member of AOA, and then completed pediatrics residency at Northwestern in Chicago. He has a longstanding interest in biosecurity and public health, and he will be speaking about the endgame of the COVID pandemic. Dan.
Thanks, everyone. A big welcome to our new chiefs, and thanks to the outgoing chiefs. Give me one moment here to pull up my presentation. Okay. Welcome, everyone. I am going to be talking about the endgame of the COVID pandemic. I have no relevant disclosures. As far as some housekeeping notes, we'll have plenty of time for questions at the end. I'll make sure of it. So please hold your questions until then. In the meantime, you are welcome to switch off your camera until the Q&A portion. I won't be looking at your faces while I talk, so don't feel obligated to leave your camera on. Also, please mute your microphone if you haven't already. About a week from now, I'll be posting my full prepared remarks, including the citations, online, so that you can take a look at my sources for yourself, and I'll put that link up at the end. I also hope to post the video of this talk online on YouTube. This is my second consecutive year giving grand rounds about the COVID pandemic. Let me introduce my background. As Dr. Duffy mentioned, beyond caring for patients, my academic interest is in biosecurity, which is the field that deals with global threats to health, including pandemics. And this interest was deepened by two experiences in college. I completed Stanford's undergraduate honors program.
Your audio went away, Dan.
I'm sorry?
Dan, something happened to your microphone. It might be covered.
Ah, that's quite possible. Is this better?
Yes.
Okay.
Yes, it's fixed.
Noted. Okay. So I don't know where I cut out, but in college, I studied international security studies in an honors program. And then later during college, worked at the US Department of State and was the Science Advisory Office's team lead on the H1N1 flu when it first emerged. And so inspired to work on medicine and public health, I entered medical school at UC Davis, and during medical school, rotated at the CDC's influenza division and was deployed on a disease outbreak investigation alongside officers in the CDC's Epidemic Intelligence Service. During pediatrics residency, I completed a part-time fellowship in biosecurity at the Johns Hopkins Center for Health Security, which is the current academic hub for the field. That then brought me to dermatology residency. During the interview day here, Dr. Neum, Dr. Colvin, and Dr. Sidbury made clear that if I came here, they would support my biosecurity pursuits, and the program has certainly done that. During my first year here, I got sent to Maryland to take the US Army's week-long medical course on how to care for patients during chemical and biological attacks. I was hoping that my background in biosecurity would be a curiosity, and unfortunately, it's been rather relevant during this past year. Today, I'll be first discussing new research findings on masks, which might make you rethink your current approach to masking. Then I'll teach the reproduction rate, which is a useful framework for thinking about any pandemic, especially this one. I'll discuss how new mutant strains are changing the course of the pandemic, and I'll try to paint a picture of what the end of this pandemic could look like and the steps we can take to get there. Lastly, I'll briefly give some concluding observations on this pandemic and what we can take from it. Now, my work is cut out for me today because all of you have become experts in COVID over the past year. I've lost my edge. And so as a result, I'm going to be jumping a lot from topic to topic, skipping over the things that I think you already know in an attempt to focus on things that you possibly don't. So to begin, let's discuss masks. The CDC and the medical community have finally acknowledged that COVID spreads, at least partly, through aerosolized spread. N95 masks are considered superior to other masks at filtering aerosols. It might surprise you to learn that there are plenty of N95 masks available right now in the US for purchase. A number of US companies stepped up to make N95 masks, and some are having problems selling their surplus inventory. Large suppliers tend to contract with large manufacturers, and that leaves these small manufacturers behind. And most people don't know that N95 masks are available or think that they shouldn't buy them to reserve them for medical personnel. The New York Times recently detailed how some US companies that are making N95s have started laying off workers, and some are even at risk of going out of business. And then a few days later, they published a guide on how you can buy an American-made N95 mask. And there are indeed several American manufacturers that have N95 masks in stock and available to the public. My brother tried it out and he had no difficulty getting a box of N95s for himself and his family. One issue though is that the public generally does not have the ability to fit test an N95 mask. So how much does that matter? This question was the subject of a recent study which looked at how well 7 men and women fit various N95 and KN95 masks. The masks were made in the US and China. For the experiment, they used this quantitative fit testing device. It sprays a saltwater aerosol mist on the outside of the mask and then detects the concentration of submicron particles on the inside of the mask. UW Employee Health does have a similar machine that it uses for quantitative fit tests. Here you can see the masks that the participants wore. At the bottom right is a KN95, which is a slightly different standard from N95. And then the rest of the masks pictured are N95 masks. First, here are the results showing how many participants fit each type of mask. And you can see that in the study, the US made N95s fit the most people, and also that each mask tended to fit fewer than half of people. Now, this graph is really interesting. Each participant rated whether they thought that the mask that they were wearing was a good fit or a poor fit, without knowing the results from the fit test from the machine. And every time a participant thought a mask didn't fit, they were right. But when a participant thought a mask did fit, they were only right about 35% of the time. The study found that you can't be sure that a mask fits without undergoing fit testing. They also assessed how well the masks filtered when they didn't fit. The N95s still did mildly better than a surgical mask or a fabric face covering, even when they didn't fit. The KN95 mask that they tested didn't have any advantage over any other mask. I took 3 main takeaways from this paper. The first is that an N95 mask doesn't have much benefit unless it fits. The second is that if an N95 doesn't fit, it still doesn't seem to be worse than any other mask. And the third is that I don't trust KN95 masks. The next paper is from JAMA Internal Medicine. Here, a single participant tried on a number of masks. And again, a quantitative fit test device determined what percentage of submicron particles the masks filtered out on inhalation. He tried on various consumer masks that are available to the public, like a nylon mask, a bandana, and a balaclava. He also tried a procedure mask with ear loops pictured at the upper left, which looks similar to what we use in clinic. And then they also modified the procedure masks in various ways to try to improve fit. Here are the results. I'm going to display them another way in a moment. As a control, they tested an N95 mask, which filtered 98% of particles as expected. But perhaps surprisingly, the procedure mask stacked up poorly compared to the commercially available masks. I put the result by the mask type, and this is on a scale of 100, with a higher number meaning better filtration. You can see that a cotton bandana filtered aerosols better than did the procedure mask. Here are some of the procedure masks, and modifying the procedure mask so that it was pressed tighter against the face did make it filtered better. The best was when a nylon stocking was put over a procedure mask. It would not surprise me if procedure masks are bad at filtering air. My understanding of physics would suggest that air tends to travel along the route of lowest resistance, and the procedure mask, as seen here, leaves gaps at the side. Now, it's hard to generalize this study because the masks were only tested on one person's face. That said, there is a theme here that shows up in other papers, which is that the seal and fit of the mask matter. Now, I don't know whether we should have to guess whether hospital-provided procedure masks provide good filtration when we wear them. As I mentioned earlier, our institution does have quantitative fit test devices, just like was used here. And I'd be very curious if we could have our own procedure masks fit tested and see what a quantitative fit test would reveal. Another paper worth mentioning was published in February in MMWR, which is the CDC's epidemiology journal. A CDC team placed masks on mannequins that emit an aerosol spray and saw how well the masks filtered the inhalation and the exhalation. The publication of this paper in MMWR coincided with the CDC's recommendation that the public double mask. I personally don't find this study compelling because it doesn't use humans, but I'm including it because it received significant media attention. The next paper I have is a technical report by NIOSH, which is the government agency that regulates respiratory protection. They tested 12 different N95 and N100 masks that have exhalation valves, as shown here. Here's their setup. And what they found was that masks with exhalation valves were generally comparable to procedure masks with respect to source control. And also that they compared quite favorably, sorry, I just lost my thread here. They compared quite favorably to cloth masks. And you can see it here. It's possible that the reputation that exhalation valves have is undeserved. All of these papers together vindicate my preferred form of respiratory protection, which is the elastomeric respirator. Elastomeric respirators have been widely available throughout the pandemic. They're inexpensive at about $20 to $50, and they're fully reusable. They fit better, they're more comfortable than N95 masks, and they don't fog up your glasses. In the photo here, I'm wearing P100 filters, which filter better than an N95. One significant advantage is that an elastomeric respirator allows you to perform a reasonably good fit test on your own without any special equipment. One respirator can last years, which has an environmental benefit over disposable masks. Manufacturers have worked to address concerns over the exhalation valve. There are two manufacturers, MSA and Dentec, that are selling elastomeric respirators where you breathe back through the filter. And 3M now sells an accessory for one line of its respirators that filters out the exhaust. I'm a big fan of elastomeric respirators, and I'm still disheartened that only a handful of hospitals nationwide are using them. With the recent revelation that UW's N95 supply is compromised and that staff have been using counterfeit N95 masks of unknown efficacy, I think there's more reason than ever for the hospital to use elastomeric respirators, especially in the COVID wards. And I still don't understand why they won't. My philosophy is if you're going to wear a mask anyway, why not wear one that is fully protective? So some of the takeaways: first, that N95 masks are widely available, but unless they're fit tested, you can't be confident that they work better than any other mask. Second is how well a mask fits seems to matter more than what material it's made of. Another is that unless they're modified, procedure masks with ear loops may be relatively poor at filtering air and at protecting others. And last, even though they haven't caught on, elastomeric respirators are available, inexpensive, and fully reusable, and they filter better than an N95 mask. Now to move on to epidemiology. A helpful lens for thinking about any pandemic, including this one, is through the reproduction rate. One part of the reproduction rate is the basic reproduction rate, which is also called R0. R0 is defined as the expected number of secondary cases that result from a primary case in a population that has no immunity. Put another way, it's the average number of people that an infected person will go on to infect in a susceptible population. Since R0 refers to a population that has no immunity, it doesn't account for vaccination or immunity due to infection. The best estimates give COVID-19 an R0 of around 2.5. So before social distancing, each infected person went on to spread COVID to about 2.5 people. On average, maybe half of transmissions come before an infected person ever shows any symptoms. Closely related to R0 is which is the basic reproduction rate, is R sub E, or R. I'm going to call it R during the remainder of the talk. This is the effective reproduction rate. So this is the true reproduction rate in a population, accounting not just for environmental factors and behaviors, but also for immunity. Now, currently, R is less than R0 because a decent portion of the population has some degree of immunity to COVID. In an outbreak, if R is greater than 1, the number of new cases will increase exponentially over time. If R is less than 1, the number of new cases will decrease exponentially over time. And if R approximates 1, the number of cases will remain roughly stable over time. This is fundamental to understanding how a pandemic goes. Now, we have strategies that can reduce both R0 and R, and that includes contact tracing, testing, isolation, quarantine, social distancing. There are items that exclusively reduce R as well, and that is vaccination and also immunity through infection. One other point is that it's easier to maintain an R equals 1. It's easier to maintain an equal number of cases when the overall number of cases are low. And that's because contact tracing and isolation and testing all work better when cases are low. Understanding R0 and R makes it somewhat possible to predict the future. I learned that some senior faculty in the division had nicknamed me Danny Downer because of my gloomy but ultimately spot on predictions about the course of the pandemic. But occasionally I make optimistic predictions too. And here's proof. I have a time-stamped prediction that I made back in August that this winter's flu season wouldn't take hold. And I figured this because the R0 of seasonal flu is about 1.2 compared to the R0 of COVID, which is 2.5. Flu spreads primarily through the respiratory route. And so any measures that would bring down the R0 of COVID would also bring down the R0 of flu to well below 1. And indeed, this year, flu has barely registered a blip. in the entire US, there's only been one pediatric death from flu this entire season. Another powerful tool in predicting the future is the epidemic curve, which shows the trajectory of case counts over time. Looking here at the US epi curve, we see periods where R was greater than 1, like here, where R was less than 1, like here and here, and also areas where R roughly equaled 1. If you look at the y-axis, you'll note that this is a logarithmic scale. And that's my preferred way of looking at an epidemic curve. Outbreaks behave in exponential terms, and so a period of exponential growth renders as a straight line on a logarithmic plot. And I'll show you an example of why logarithmic plots are helpful. Now, if you were to look at this linear plot here, and I were to ask, where is R higher? Is it higher over here in the initial surge, or was it higher over here when cases really shot up? It's really difficult to tell because we're not primed to interpret curves quite as well as we are at interpreting straight lines. And then if you look over at the right side, though, it becomes very clear. R was much higher at the outset of the outbreak than it was here. Now, the log plot has another advantage in that it's very easy to visualize the future by looking at the trajectory. If the outbreak at first were allowed to continue without any controls put on, you would see that it would track along that original line and you could see where things would head. And same with times where cases are going down. You could do things like project how long it will take for cases to get to a certain number over time. And although most graphs that you see are linear plots, I find the logarithmic plot much more helpful. So understanding the reproduction rate is important, so important that I went over it this year in addition to last year, because it helps us to understand the mutant strains a bit better and what the consequences of these new mutant strains are going to be. I'm going to discuss these mutant strains in more depth, and then I'll tie them back into our conversation about the reproduction rate. So the technical name for the virus that causes COVID-19 is SARS-CoV-2. It's an RNA virus. Now, for the step 1 exam, we all had to memorize which viruses were RNA and which viruses were DNA. And for the life of me, I could never figure out why we had to memorize such a stupid fact and what possible clinical or conceptual benefit there could be from knowing this. And in preparing for the talk today, I think I finally found one, and here it is. RNA-based viruses tend to have higher error rates than DNA-based viruses when they replicate. And some of the most stubborn infections, such as HIV, hepatitis C, and influenza, are RNA viruses, and their frequent mutations help to frustrate our attempts to make a vaccine. Now, most mutations in SARS-CoV are inconsequential, but a handful of mutations have been game changers because they make the virus spread more readily to other people, they make people more sick, they make the virus evade the immune system, or some combination of the three. We have formal terms for these three qualities: transmissibility, the virulence, and immune escape. Some more definitions for you. The WHO has come up through a useful framework that helps us categorize mutants. Variants of interest are those that deserve further investigation. Variant under investigation, I think, is self-explanatory. And then a variant of concern is a variant that's been confirmed to have a change in the transmissibility, the virulence, or to exhibit immune escape. So how can we identify mutant strains? When we sequence a patient's SARS-CoV-2 genome and identify a new mutation, it would be nice to be able to then project whether that mutation will make the virus more transmissible or more virulent. But our ability to do this is unfortunately quite limited because it's very difficult to predict the three-dimensional conformation of a protein from its genetic sequence alone. Instead, we mainly rely on epidemiology to identify which mutant strains are worrisome. The UK identified B117, which is the mutant strain that is currently taking hold in the US, because they've very prudently been sequencing a significant portion of their country's COVID samples. It discovered that one particular strain, which is seen here in dark purple, had rapidly become the predominant strain in the country, crowding out the other strains that had been circulating for many months. By carefully tracking how quickly the new variant was taking hold, the UK's public health agency was able to calculate how much more transmissible the new strain was relative to the wild type strains. It also was able to identify that the strain was more lethal because a rise in the case hospitalization rate and the case fatality rate, meaning the proportion of cases that end up in the hospital or who end up deceased, was increasing in tandem with the increasing predominance of the new strain. The UK's public health agency seems to have done an excellent job of identifying and characterizing the B117 mutant strain, and they've been quite transparent about their findings. But even when done right, the process is slow. B117 probably first developed in October. The UK identified it as more transmissible in late December, and they identified it as more lethal in late January. By the time it was identified, it had already spread around the globe. And so the stable door was necessarily closed only after the horses had already bolted. And let's take this analogy a bit further. It would be nice to be able to look at a horse and figure out if it was likely to bolt from the barn so that you could secure it better. But we largely lack that ability. And so in the UK, they noticed that most of the bolting was being done by a new type of horse and then worked backwards to identify it. For other mutants, the process has been clumsier still. Brazil and South Africa saw massive increases in their epidemic curves and noted that a number of infections were occurring in people who had already recovered from COVID. This observation sparked a hunt for the responsible mutation. And so to return to the analogy, these countries looked for a mutant because lots more horses than usual were bolting from the barn. The point is, we can't really identify mutants until they have already mutated and spread. The UK, Brazil, and South Africa have done a commendable job of genomic surveillance. I don't know that we can say the same for the US. Only since the new administration has taken power has the CDC started sequencing a meaningful number of viral samples in the US and in a systematic way. We have so little data from before that it's difficult to know whether the main variant strains circulating in the US are truly variants of concern. And that's why there's such a question mark over whether new strains in New York or California actually change the game. And so it's doubly unfortunate that the press has dubbed mutant strains as the UK strain and the South Africa strain and the Brazil strain, because these countries have done a good job and transparently shared their data with the world. And what's their reward? Well, we penalize and stigmatize these countries by naming the mutant strains after them and maybe cut off their air travel. And I don't think it's lost on these countries that if they didn't say anything, then another country that came forward with information about the strain may have been labeled with it instead. So one challenge that urgently needs to be solved is we need a system for giving new COVID strains neutral names, similar to what we do with hurricanes. Now, figuring out whether a strain is vaccine resistant is also a cumbersome process. Vaccine manufacturers synthetically generate surface proteins of the wild type virus and a mutant virus, and then they mix the serum of vaccinated people and see how well antibodies bind to the surface proteins. When they find a decrease in antibody titers, how does that translate into a change in real world immunity? Unfortunately, we don't completely know. And that's partly because the lab test can't assess T cell response, which has an incompletely understood role in immunity. These types of trials and also clinical trials and epidemiological studies give real world data, but they take time and they're expensive to pull off. So to sum up some of the takeaways of this section, identifying mutants requires both sequencing lots of COVID samples in a systematic way and analyzing their epidemiologic trends. Recognizing that a mutant strain is a true variant of concern is a months-long process, by which point it will already have spread widely. Taking a closer look at our current variants of concern, B117 is the mutation that's currently taking hold around the country. While our understanding of the strain is still evolving, it appears to be more transmissible by about 50%, and also appears to be more virulent with an increased lethality of about 50%. It doesn't seem to show significant antigen escape, meaning that people who are vaccinated or who have natural immunity appear to still be immune. But the transmissibility in particular ends up having major ramifications. Looking at the epi curve of the US again, recently cases were dropping with an R of about 0.9. Now, an R of 0.9 for the wild type strain still equates to an R of around 1.1 for the B117 strain. And so while cases of the wild type strain have been decreasing, we can predict based on our understanding of R that cases of the mutant strain have been increasing exponentially all the while. It's hard to confirm that because of our underdeveloped genomic surveillance, but there is some evidence. Some of the best evidence has come from a company called Helix that performs COVID testing. They use a fairly standard PCR test on their COVID samples, which happens to have a change called S gene dropout when they perform a PCR test on one of the mutant strains. This ends up being an indirect marker that can alert them to when a strain might be a mutant. What Helix has been doing is tracking what portion of its PCR samples each day show this indirect marker, which is called SGTF, S gene target failure. And that gives us a sense of how quickly the B117 strain has been taking hold. Here are the data as of February 27th, and I apologize that it's a bit small. They found that 36% of their most recent samples from Florida were the mutant strain. They found also that in California, about 17% of samples were mutants. They published a preprint in early February that estimated that the B117 mutant strain would be the predominant strain by early March in Florida, and also that it would be the predominant strain by late March in the United States as a whole. They predicted that it would be predominant in early April in California. So far, their estimates have been right on track, and that makes it a race against time to get people vaccinated. That said, vaccination is starting to go great. The Biden administration announced just yesterday night that they will now have enough vaccines by the end of May for every American to be vaccinated. That's remarkably fast. It could be a true game changer, and it may mean that we can get vaccines in people's arms faster than the mutant strain is able to take hold. There's another big issue with B117's increased transmissibility in that it changes the threshold for herd immunity. The herd immunity threshold is the percentage of people who need to be immune in order for R to equal 1. Hitting herd immunity doesn't mean that the outbreak is over. It's just the point where the outbreak would resolve over time on its own, even if we returned to normal life. It doesn't mean either that hitting that threshold is the point where it's safe to return to normal activity, because people would still be transmitting the virus to each other. It just means that the outbreak is headed towards resolution. The equation for herd immunity is shown here. It is R naught minus 1 all over R naught. For the wild type strain, it's about 60%, but with the B117 strain, the threshold becomes 74%. And it's not, keep in mind too, that vaccinating 1% of the population doesn't translate to a 1% increase in immunity. Our best vaccines are only 94 or 95% effective at preventing symptomatic infection. And the new Johnson & Johnson vaccine is 70% effective. And what we really need to know, but don't, is how good the vaccines are at preventing transmission. There's a demographic issue too. About 20% of the US population is under the age of 16, which means there's only 80% of the population eligible. We have a ways to go. Working in our favor is that there's natural immunity through past infection, but it's not known how long this immunity lasts, and at least one mutant strain, the P1 strain, eludes natural immunity. And so these mutants are a warning shot. They're telling us that without decisive action, we won't be able to get back. Without decisive action, we might approach a point where we can't achieve herd immunity. Important to note also is that vaccination alone can't get us back to normal, at least not in the near term. We can look at Israel, which has predominantly the B117 mutant strain and leads the world in vaccination. Over 50% of their entire population has received the first vaccine compared to 16% in the US. But if you look at their case numbers, they're quite high. This is a graph of the cases per day per capita, and you can see that they have more cases per capita right now than the US. So vaccination is good, but it's not enough. It also isn't the only thing that you need. You can eliminate COVID without vaccination. And several countries like New Zealand, Australia, Singapore, and Iceland have demonstrated that. And even in countries where the mutant strain is circulating, like Portugal or Ireland or South Africa, they've all managed to bring R back below 1 by using the usual toolkit of fighting a pandemic. If they can do it, so can we, especially since we have an added benefit of a robust supply of very effective vaccines. It's always been possible for us to eliminate the virus in the US, and that's still true. So then when can we get rid of our masks and go back to mingling with strangers at the bar and seeing concerts and going to baseball games? I think the epidemiologic analogy of that is that we can do those things only once there's minimal transmission of virus in the community, because our vaccines are not perfectly protective. And there are some strategies globally and locally that could help get us to the point where COVID transmission is 0 or nearly 0. Globally, one of the most urgent needs is for us to decrease the likelihood of a new mutant emerging. We can't afford to have another mutant come along that's more transmissible or more lethal. If there were fewer cases globally, that would mean that there are fewer viral replication events, and that means fewer opportunities for new mutants to evolve. And so it's going to be important to dramatically increase the pace of vaccination worldwide. We need to contemplate helping other countries develop domestic vaccine production, and we may even need to give them our intellectual property on how to make vaccines. I'd also love to see increased investment in the COVAX program, which is a WHO program funded by donor nations with the goal of achieving universal vaccination worldwide. Helping other countries control COVID not only is the right thing to do, but it would keep us safe. Interestingly, too, to prevent mutant strains from emerging, we might need to stop using convalescent plasma. That's plasma from recovered people. And there are some early signs that, that convalescent plasma can help to generate new mutants in patients who have chronic COVID infections. Another way to combat mutant strains is by updating our vaccines. The FDA has been proactive, and they've announced to vaccine manufacturers that they won't have to start from scratch with their clinical trials. If they develop new vaccines for the new strains, it would be regulated more like how they regulate the seasonal flu vaccine. It's good that there are lots of vaccines in development with lots of targets and lots of methods, because it gives us a diverse arsenal in attacking the virus. Domestically, we can further drive down R by tightening up on our pandemic fundamentals. This could be by improving the quality of our masks. It could be by increasing access to testing through low-cost home COVID tests. The technology is there, but they're not sufficiently available or affordable because of regulatory obstacles. We can improve our population-wide surveillance by testing sewage, which is done in some countries around the world. We can do more to isolate people, to give people a place to recover from COVID without exposing their household members, or where someone who's exposed can quarantine without putting their household at risk. Not all cases nationwide are being contact traced, partly due to a shortage of contact tracers. Better sick leave policies would let people stay home from work when they're sick, and subsidies for businesses like bars and restaurants to stay closed to in-person dining would decrease opportunities for the virus to spread. The surest path to getting to COVID zero is to drive R permanently below 1 through immunization and natural immunity. An analogy here is measles, where even though measles is extremely transmissible, it has an R naught of 12 to 18, it has a highly effective vaccine, and just enough people have the measles vaccine that measles isn't able to take a hold in the US. With COVID, because the herd immunity threshold is so high, and because there's such a high rate of vaccine hesitancy, vaccine refusal, and what I'll call vaccine ambivalence, it's going to matter a lot how many people who are on the fence we can convince to get the vaccine. Possibly by April, we'll have vaccinated the entire portion of the population that's willing to jump through hoops to receive it. Soon, we're going to have to tackle the rest of the population. The Johnson & Johnson vaccine, which doesn't require special refrigeration, is only a single shot, might be a great option for places like primary care clinics or maybe even our dermatology clinic to give it to patients who are on the fence about a vaccine. Because the rate of vaccine hesitancy is so high, it may require mandating some groups of people to receive the vaccine. And that's going to generate lots of policy and legal questions about what sorts of carrots and sticks we can use to ensure or compel vaccination. The courts have generally found that the government has sweeping public health authority. And in 1905, the Supreme Court decided in Jacobson versus Massachusetts that Cambridge, Massachusetts could mandate that its residents be vaccinated for smallpox or otherwise pay a fine. The federal government also put out guidance in December that once the FDA approves a vaccine, employers can legally require that their employees receive it before they're allowed to be on site. The legal precedent here is clear, but with the current court's more conservative makeup and with the Supreme Court's recent decisions to rule against states' efforts to limit gatherings at churches, it remains to be seen whether the current court is going to follow this prior precedent. Even if we can't pull off universal vaccination, it's still possible to eliminate the virus. It's possible to bring R down low enough in the coming months to completely eliminate the virus in the US. And then if we pulled that off and massively bolstered our border controls, we could keep the virus eliminated within the US. So these are some of the developments that I'll be looking out for that I think are going to be important waypoints on the path back to normalcy. One is that there is sufficient supply to vaccinate every adult. And according to the Biden administration, this will probably happen sometime in May. Next is that the FDA needs to approve a vaccine. None of the vaccine mandates are going to happen until it's officially approved. Currently, it's only authorized under an emergency use authorization. Next is when a vaccine is approved for children. This could happen in the fall. Another is when workplaces, schools, and maybe airlines mandate vaccination. I wonder if also health insurers might have it so that there's a higher premium for those who refuse COVID vaccination, similar to how they can charge a higher rate to those who use tobacco. These, any mandates are inevitably going to generate court challenges. And so another step is that the judiciary would need to affirm the legality of those mandates. And then we need some sort of infrastructure for travelers from abroad who aren't vaccinated or who are coming from high-risk areas. If I could encapsulate my philosophy on fighting pandemics, it's that we have to maintain R less than 1 without letting up. If you want cases to get low or get to 0, then you need the case count to decrease. Our year-long game of letting cases surge until they're out of control, really briefly imposing controls and then loosening them again, hasn't worked, and it will never work because it runs up against the inescapable fact that when R is greater than 1, cases increase exponentially. And when you have an exponential increase in an already large number, it makes an enormous number. Hoping that when cases go up, they'll only go up slowly is like hoping that you can make your house warmer by lighting fireworks. You can't have a controlled burn of exponential growth. Right now, we have our newest test in front of us because cases have stopped declining and maybe are poised to go up. And so our nation's new question is, have we learned our lesson and are we up to the challenge of having consistent, protracted decline in cases? Predicting the future of the pandemic is difficult because pandemics are a contagion of disease that require a political response. And this means that there are two parts to predict: the virus and our response to it. I find that the virus's behavior is the easier one to predict because the virus plays by virus rules. And those rules are intuitive if we think of them in terms of things like the reproduction rate and the epi curve. Harder to estimate is our political response, but a lot of things in our political response are going right. Our federal response is dramatically better. Some of the leading experts in biosecurity are now advising the Biden administration, and the administration seems to be following their advice. And the CDC is finally unmuzzled and unshackled and has been giving what I think is generally good quality advice. We're quite fortunate to have 3 high quality vaccines in the US, and the number of vaccines being given each day is picking up rapidly, and we should see a dramatic increase in supply in the coming weeks. People pay a lot of attention to public health during an emergency, and then we tend to ignore it once the emergency is over. When public health works well, the deliverable is that nothing happens. And so I hope that we won't forget the lessons that we've learned during this pandemic about how important it is for us to work on public health. I hope we'll perceive it as our duty to care for patients, not just as individuals, but as a population and as a public. I want to close with a note of genuine optimism. I believe we're in the end game of this pandemic, and it wouldn't surprise me if we could return to our usual domestic life by the end of the year. If so, I look forward to us celebrating it in person. I have a number of people to acknowledge, and I especially appreciate how enthusiastic the program has been in allowing me to pursue my passion for biosecurity. Thanks to everyone for giving me the opportunity to deliver grand rounds today. I'm supposed to remind you to please fill out this evaluation, and with the remaining time, I'd like to open the floor now to questions and discussion. Thanks very much.
Dan, awesome job. Much, much deeper analysis than you get from most places. Raises a million questions. I think you probably saw the New England Journal this week about convalescent plasma and absolutely no benefit in sick patients who are already in the hospital. But you're adding fire to that argument that it is not good or not beneficial, and also saying it's actually helping to spread more resistant.
Maybe. So I'm sorry that I don't have that paper pulled up. There are a few preprints out that have looked at the samples over time from patients who've received convalescent plasma, and they show that the mutation rate goes way up after convalescent plasma has been given. And in one patient in the UK, they developed one of the mutations seen in one of the mutant strains spontaneously after receiving convalescent plasma. So I wouldn't say that it's slam dunk evidence, but it's enough to make us think that maybe it's not worth using, especially because we have monoclonal antibodies that work great and that aren't a threat to developing immune escape.
Dan, I have a question about masks.
Yeah.
So I think both last grand rounds and this one, you presented compelling arguments about the theoretical filtration of particles. But how is that translated to where the rubber meets the road with, for example, healthcare worker infections in a relatively controlled setting where there's universal masking, generally of non-N95 types? And has there been data to support the filtration theoretical data?
I've not seen much. Even, we've had the experience in our division of more than one healthcare worker contracting COVID despite wearing surgical mask and eye protection. And that's not really documented in the literature. Like there are hardly any even case reports. So I wouldn't say that this has been studied in a systematic way.
Yeah, I mean, I hear, and for example, had a patient who is a VA nurse who says what's happening at the VA, at least in her sphere, is wearing N95s and basically until they are gross. In other words, being put on, taken off, and not being used in the way that they're intended. So similar to the way that people use sunscreens imperfectly, I'm just wondering if how applicable the theoretical data is to real life setting.
Sure. Anyone else? And let me take a look at somehow I can't pull up the chat here. I'm going to get rid of my screen here. You've mentioned chronic COVID-19 infection. How do you define that? In the paper that I'm referencing, if I'm remembering it correctly, it was a patient who had like ongoing viremia at high levels for like 3 months. It seems to be really rare, and it's more common in immune suppressed people. But from what I understand, there are cases of people who just have who don't clear COVID in any rapid form.
Dan, I have another question, if that's okay. It's sort of a follow-up to Roy's question about the masks. There's a lot of the theoretical sort of studies that some of which you mentioned that are really interesting. But and you're right that these individual cases of positive, healthcare workers getting it, for example, in the derm division, exist and aren't well documented. But overall, the sense from our experience at the Polyclinic and your experience at UW, watching the rounds, is that the regular surgical masks that we are wearing, our protocols, are by and large pretty effective. The infection rate for employees is lower than the infection rate in the community in most times I've looked at it.
I still don't know if I agree with that bit about healthcare workers having a lower rate of infection. But go on.
So anyway, I guess the question is, how does the theoretical translate to the real? It's the same question as Roy. Again, knowing that they're not documenting the case reports very well, but getting the sense that it's generally working.
I don't have a great answer for that. I mean, my philosophy has always been that if there's a risk that you can easily mitigate, why not? And for example, we put so much focus on eye protection and wearing face shields instead of just glasses and the evidence there is much weaker that a face shield is better than eyeglasses. It seems a lot of what we do in medicine is making good decisions without the best evidence. And I feel like there's enough evidence here that there's aerosolized spread that at least I don't feel comfortable taking that risk. I do wish there was a more robust evidence base. If there were a random controlled trial or something like that, it would be a lot easier to sort out this question.
Thanks.
Dr. Sibrey raised his hand.
Yeah, go ahead, Rob.
Trying to be virtually polite. So Dan, that was awesome. Thank you. I just have a question here. You mentioned the sort of pejorative nature of the naming of these diseases, and obviously it's been true not just recently with the past president and the use of the China virus, et cetera, but with the Spanish flu in 1918.
Yeah.
You brought it to another level about the suppressive effect of countries not wanting to give out information. So it takes on a whole nother element there. What is the tipping point? How do these things get named, and what's a policy or a direction that can be taken to try to change that?
Yeah, I've seen some science journalists try to come up with solutions on their own. They suggested bird names, which I think is great. But I think the WHO is the best group to handle something like this because they're an international mechanism and they do things like they came up with the name SARS-CoV-2 as the virus because they didn't want to be called any geographic name. So I don't know how you can compel the WHO to do something, but I think that's that, or maybe the CDC or the IDSA, some large organization, could probably be the impetus to come up with a more neutral name. And, you know, would it be Greek alphabet, Greek gods? I don't know, but just we need something because the numbers are really difficult to follow. With that, it looks like we are at the end of the hour.
Actually,
So,
Dan, I
yeah,
have
go
a
ahead.
question.
Yeah.
So how do we anticipate the next pandemic? So you worked on H1N1. We've had SARS-CoV-1. We've had MERS. We have SARS-CoV-2. I understand that the previous president shut down funding for an institute in Hunan, which was actually studying these viruses. How do we anticipate the next one? And is there anything we can learn from this one?
Yeah, and that could be a whole other talk that I would love to give about how we can prevent the next pandemic. And a few things. One is that it would be nice to have an actual forecasting center in the government tracking this. And maybe intelligence agencies have this, but certainly there's not something for the public the way that there is for hurricanes or volcanoes or weather events. And that's something that it wouldn't surprise me if this administration ends up adopting is a outbreak observation center. And I think that would be great to have people just dedicated looking at pandemics on the horizon that may need attention. Another thing is that a great way to combat a pandemic is to have really good existing infrastructure. The worst time to build infrastructure is during a crisis. And we're seeing this now that if you have access to care, if you have an unemployment benefits system that is modern, those are things that you can call on during a pandemic to help get you through it. So I do think a lot of, if not preventing the next pandemic, making it so that the next pandemic isn't as troublesome or can be cut off sooner is to focus on making our infrastructure so that it works really well. And one last thing to bring it more towards us as doctors is that there's more that we can do to incorporate public health into even dermatology. So, or even our institution, let's say. So the example I'm thinking of is that there is a medical specialty called preventive medicine. It's one of the original boarded medical specialties. Hardly anyone goes into it. It's like 0.1% of med school graduates go into it. And it's the only medical residency that isn't funded with Medicare dollars. The money comes from AHRQ, which is this perpetually underfunded public health bureau. And they can't even generally pay a resident's full salary in a preventive medicine program because the funding is so poor. If we just had it so that doctors had more opportunities to train in public health, or if we were to expand things, the same way that you have an MD, PhD in basic science, if you could have that in epidemiology or have fellowship programs in epidemiology, you could at least have a really deep bench so that institutions and government agencies are seated with folks who really know what they're doing. When I was at the State Department, I ended up being something of an expert on flu, despite being an undergrad, because there were hardly any doctors at the State Department. And there wasn't really a recruiting opportunity for doctors to work there. So the bench wasn't very deep, and that's not great that, that a college student ends up advising, ambassadors and things on flu. So if we made it so that we were more multi-purpose in our training and more multi-purpose in where we could practice, there would be a deeper community of people at all parts of government and all around the country able to act when a pandemic strikes. And that's really better than having a central mechanism, is having it decentralized where you have lots of people who know what they're doing, spontaneously making their own good decisions.